All right, so we're going to continue with the second part of the renal physiology. We talked last time about the glomerulus, and we talked about how substances, if we look at that membrane here, we can see the difference between the membrane of the nephron and the peritubular capillaries, and this was up in the proximal convoluted tubule. So this process of taking substances from the tubule, from the proximal convoluted tubule, into the blood, what we call that generic process. Well, let's go back. Let's take a step backward. Up at the glomerulus, under the influence of hydrostatic capillary hydrostatic pressure, we have just a passive, non-selective pushing of fluid out of the glomerulus into Bowman's capsule. What do we call that passive pushing of fluid? Filtration. Filtration is the generic. It's going from blood to nephron, right, to the Bowman's capsule. Now it leaves Bowman's capsule, enters into the proximal convoluted tubule. Now we need to get that good stuff back into the blood, right? And when I say the good stuff, what is that? What do we not want to urinate out? We need to get it back to the blood. Glucose and amino acids and a lot of the volume of our plasma. Yeah, a lot of that water has got to be, what is that process of going back to the blood? Yes, that's the answer. Tubular reabsorption. So that's what we're going to focus on today, is this process of tubular reabsorption, because each part of the nephron has like a special role in that reabsorption. Or if the opposite is true, if we need to get rid of something from the blood and put it into the nephron, the third process that occurs, so we have filtration at the glomerulus, tubular reabsorption throughout the nephron, and then this putting back into the nephron from the blood extra things like sodium, potassium, hydrogen ion. What do we call that movement back to the nephron? Secretion. Secretion. So know the difference between those three substances, because we're going to use the terms reabsorbed, secreted, and you have to know what direction substances are moving or it's going to be really confusing, okay? So secretion is going from blood to nephron, reabsorption is from nephron to blood, and filtration is from blood to nephron. But of those three, we can say that filtration is the least selective. It's just based on push. And what determines capillary hydrostatic pressure in the glomerulus? What's the number one determinant of that? Someone besides Grace? Just because I want to get... Grace will go down in time online as the first to volunteer. But I just want other people to think about it. And I had Grace as a student last semester, so she knows the questions I ask. She knows kind of what I focused on in general ENT. So, anybody? What is capillary hydrostatic pressure? Which direction does it act? Out of the nephron, or out of the glomerulus, or into the glomerulus? Pushes out of the glomerulus. Okay, so we're pushing fluid out. What determines how much push is in that tuft of capillaries? I know you guys know this. Solute suck. Amount of fluid is what pushes. So what determines the amount of fluid going into the glomerulus? Blood pressure? Yes, the systemic blood pressure. Systemic blood pressure is going to determine that. And remember, the afferent arteriole has some autoregulatory abilities that if pressure is too high, what is the afferent arteriole going to do to protect that fragile glomerulus? What? Constrict, right? And if blood pressure falls, to make sure we get glomerular filtration happening, what is the afferent arteriole going to do? Dilate, yeah. So those are some potential test questions, as you can see. Those are just some key concepts of basic understanding of what's going on once we get into the glomerulus and beyond. Okay, so today we're going to talk about more about this reabsorption in the proximal convoluted tubule. We have what's special about it. It's the site of where most reabsorption occurs. Because of the filtrate that is formed in Bowman's capsule as a result of the squeeze out of the glomerulus, only 1% of that is going to become urine. So we squeeze this volume out. Remember, we squeeze our whole plasma volume out every, what did we say, 22 minutes, right? So you know, that's a lot of volume passing through there. But because of reabsorption, we don't pee it all away. We reabsorb it back to the blood. And only 1% of what's filtered actually leaves the body as urine. So that's a key thing to know. You should write that down if you don't see it in your notes anywhere. Only 1% is going to leave as urine because of this reabsorption. So most of it occurs right at the proximal convoluted tubule, and the proximal convoluted tubule is right by Bowman's capsule and the glomerulus, right? So the minute we filter it out, we put it right back in the blood again. So where does it go when we say it's reabsorbed? What vessels are there to receive that stuff that we see listed here? Water, sodium, nutrients, ions, and small proteins. Yeah, the peritubular capillaries are there, and that's what receives it. Just like we saw in the respiratory system, we had the alveoli, right, that was taking oxygen and it was diffusing into the pulmonary capillaries, right? So now we're in the kidney, that we're talking about peritubular capillaries that are going to receive these important nutrients and take them back to the blood. So 100%, when we talk about nutrients then, make sure that you're remembering that's 100% of the glucose and 100% of amino acids, because we do not ever want to spare glucose. As much as we'd like to spare some glucose, right, and not have to save it as fat, our body is not designed to do that. It's very selfish when it comes to glucose. Okay, the loop of Henle reabsorbs selectively. So based on its based on this makeup of the walls of the loop of Henle, we find that the descending limb, as we're coming down into the medulla in these long juxtamedullary nephrons that have long loops of Henle, the descending limb is only permeable to water. So sodium cannot leave the descending limb. So water, and how does water move out, you know, across membranes? What do we call the movement of water? Osmosis. Does that require energy to move water? No, it just flows based on water concentration, right? It flows from more dilute to more concentrated. So the more solute that there is in a space, water is going to flow into that, right? We said water follows solute. So the more concentrated a space is, the more osmosis into that space we're going to see, more flow of water into that space. And then the ascending limb has a thin segment and a thick segment. When we get up to the thick segment, we see that there is active reabsorption of sodium, potassium, and chloride. So there's active transporters, which are proteins based on using ATP to actively transport. And we're going to focus on the sodium and the chloride that are present there. But potassium as well. I should just put them all together, I guess. But if you look at your diagrams, like I said, to have handy in your textbook on page 982 and 983, we're focusing on sodium chloride reabsorption. So the ascending limb is all about the salt. The descending limb is all about the water. And we're reabsorbing it. So it's leaving the nephron and going into the blood vessels. But the blood vessels are different down here in the loop of Henle in the medulla. There's a special blood vessel down there called the Vasa Recta. And we're going to talk about that today. So if we continue on then, the nephron, we get to the distal convoluted tubule, which is up in the cortex again, and it's just getting ready to connect with the collecting duct. But those two parts of, well, the distal convoluted tubule is the end of the nephron, and then the collecting duct is just kind of a sewage pipe that connects all the nephrons. But those are hormonally controlled. When we're talking about reabsorption, it depends if there's a hormone present or not, which acts on the wall of those nephrons, stimulating reabsorption of substances. So calcium is reabsorbed if parathyroid hormone is present. Do you remember that one from general A&P? If you had need for general A&P, we called parathyroid the bone breaker, right? Because it causes osteoclast activity to increase, releasing calcium to the blood. And if we have calcium in our digestive tract, parathyroid hormone is going to make sure that as that is filtered into the nephron, that we reabsorb that calcium and get it back into the blood. It's another way of sparing calcium. Water, ADH, acts on the collecting duct and distal convoluted tubule and puts little holes in it, which we call aquaporins, which are actually little channels for water. But aquaporins are the holes that are inserted with ADH. So the more leaky our collecting duct is, the more we can reabsorb water back into the blood. And then aldosterone, remember aldosterone is secreted by the adrenal cortex, and that causes sodium reabsorption, increased sodium reabsorption in the collecting duct and distal convoluted tubule. So if we reabsorb sodium, what follows it? Water. So if we reabsorb water and sodium, remember, anytime you're absorbing, we're talking about movement into the blood. What happens to blood pressure and volume when we reabsorb sodium? It goes up, yeah. So when do you think aldosterone would be released? Yeah, it's a negative feedback mechanism, right? So if blood pressure is low, the body secretes aldosterone, and the adrenal cortex secretes aldosterone, and that acts on the nephron and causes salt reabsorption, and water is going to follow. And we talked about the kidneys with renin. Remember, renin is produced by what cells? And that was part of your assignment for today, to look at that. What? The granular cells secrete renin, and renin, if you look at the flow chart that we did in the last lecture, remember that also acts on the adrenal cortex and stimulates aldosterone secretion. So we have a lot of feedback controls for a falling blood pressure. We have renin secretion, which causes eventually, right, causes angiotensin II, which causes systemic constriction of those arterioles, and then it also causes increased aldosterone secretion, which causes reabsorption, more reabsorption of salt in the nephron, and it also causes, what does renin do to the afferent arteriole? This is like probably one of the hardest questions from the entire lecture. Well, think about what the job of the afferent arteriole is. Is the afferent arteriole's job to control systemic blood pressure or to control glomerular filtration rate and protect the glomerulus? Yeah, it's a little selfish, right? It only acts locally. So if we have a falling blood pressure, we're going to constrict the systemic arterioles. We can get a good squeeze, because when you narrow a space, don't things flow faster through it, right? Like if you want to get the last bit of toothpaste out, don't you squeeze the toothpaste, right, to get the toothpaste to come out onto your brush? Same thing with your systemic arterioles. If we squeeze them, make them constricted, we get better flow, better push into our tissues, and we keep our brain alive when we constrict. If we have a falling blood pressure, we constrict. And people get that confused very commonly in the early levels of learning these things. But just think, if you want to get better flow, you got to squeeze, make something smaller. So if you have dilated carotid arteries, for example, and you stand up real quick, you get no blood flow to your brain and you pass out, right? So that's what some people have trouble, that their receptors in the carotid arteries don't constrict fast enough to increase the flow to their brain and keep their brain, otherwise people black out, right, if you don't have enough blood flow to the brain. So just remember, carry this with you into your programs, is when you constrict a vessel systemically, you're speeding up the flow and getting a squeeze into those tissues that need that blood, right, need that oxygen. But now the afferent arteriole is acting mainly to control glomerular filtration rate. It's a local control. So if blood pressure is falling, renin is going to cause angiotensin, leading through that steps of angiotensinogen to angiotensin 1 to angiotensin 2, which then is going to constrict the systemic arterioles. But it also acts on the afferent arteriole to cause it to, after all that long explanation, what's the answer? Dilate, because if we constrict the afferent arteriole, what happens to glomerular filtration rate? You're not going to have as much fluid coming in, right? So we have to dilate the afferent arteriole to keep the fluid in, to keep the pressure, because we want to increase the pressure. If we have falling pressure, are we going to get enough flow out of that glomerulus? No, we need to keep the flow coming into the glomerulus. Okay, so back to this. So the distal convoluted tubule and the collecting duct are hormonally controlled. Which one of those acts, aldosterone or ANP, again, acts to fix a falling blood pressure? Aldosterone. ANP is the only one that we've talked about so far that fixes a high blood pressure, right? So that's going to block sodium reabsorption from the distal convoluted tubule. Okay, so we talked about aldosterone, and it just basically promotes more of these sodium-potassium pumps, causing reabsorption. Secretion is reabsorption in reverse. So we're just taking things from the blood, putting them back into the nephron. So we need to secrete excesses of ammonium ion, which comes from proteins. So anything that is protein-based, as it's broken down, it releases ammonium ion. Hydrogen ion is part of, acid-base control. Potassium ion, a lot of these things come in from our diet as well. Creatinine, we talked about, a byproduct of metabolism. Organic acids would be like keto acids, ketones. All those things can change blood pH. So we need to secrete those, put them into the urine. So a slightly acidic urine, it would be expected, right, if we have maybe a lactic acid fermentation going on because of extreme exercise or something, but we would expect to see a normal blood pH, right, if the kidneys are doing what they need to do. And that was part of your case study, that first case study on fluid balance. Okay, so again, secretion is just getting rid of excesses, and we can control blood pH by controlling hydrogen ion and bicarbonate ion. So hydrogen ion, remember, makes things acidic. So if you need to reduce acidity, we secrete hydrogen ion. If we need to, if we have a high pH, we have a choice in bicarbonate ion. We can reabsorb or secrete bicarbonate ion depending if we have basic conditions, right? Because more bicarbonate ion in the plasma leads to basic conditions. So just remember, bicarbonate is base. Hydrogen ion leads to acidity. Okay, so key thing now is osmolality. And osmolality is just a term used for how much solute we have dissolved in a given volume of fluid. So if we take 1 kilogram of water, it's the number of solute particles in 1 kilogram of water. So the higher the osmolality, the more concentrated that solution is. So if we look at our body fluids, typically plasma is maintained at 300 milliosmoles. That's just the unit we use for osmolality. So 300 milliosmoles means all is right with the world, everything's in balance, there's no net movement of fluid or solute in any direction, it's homeostasis. But sometimes we need to, if fluid levels are down, we need to concentrate our urine and control this reabsorption of water or movement of solute across the nephron. So we're going to talk about an advanced concept related to renal physiology, and that's the countercurrent mechanism. So I gave you a handout, and this is from your textbook. It's on page 982 and 983, and it continues on to 984 and 985. So if you have these handy, I think that'll be helpful. But the key thing, when you hear the word countercurrent mechanism, what that means, countercurrent, means running in opposite directions. So we're basically referring to the loop of Henle. So we have the descending limb that has fluid running down it, right? And then the ascending limb has fluid running up it. So countercurrent, we have fluid going up and going down right next to each other in the medulla of the kidney. So countercurrent just means flow is in opposite directions in the loop of Henle. So again, these are all possible test questions, right? So what does countercurrent mean? It's referring to the loop of Henle, and it's the opposite flow of fluid, down in the descending, up in the ascending. So what we find is the interstitial fluid is more homeostatic as far as in balance with the rest of the tissues out here in the cortex. And as we get lower down into the medulla at the apex of a pyramid, we see the most concentrated interstitial fluid. And in the loop of Henle, the fluid in that loop of Henle is also very concentrated at the base. So if we look at the fluid inside of this loop of Henle, it's 300 at the top here, and as we dip down toward the apex, if I look at the osmolality inside the loop of Henle at the very base, it's 1200. And we're going to explain why that is today. That's the big concept. So first of all, we have to know a couple of things about the makeup of the walls of the loop of Henle. First, the descending limb is freely permeable to water. And does it take energy to move water? No. Water flows by what? Osmosis based on concentration gradient, right. So water flows out of the descending limb passively, but of course that interstitial fluid outside the loop of Henle has to be more concentrated, right, has to have more solute than inside the loop of Henle in order for water to flow. So how does that happen? How do we get a change in the interstitial fluid around the loop of Henle so water flows? Well, the key is the ascending limb. The ascending limb creates the gradient. So next to the word ascending limb, you should write creates the gradient. So it creates this difference in concentration because there's a thin portion, if you look in your diagram in your textbook again, there's a thin portion of this loop of Henle and there's a thick portion. The thick portion has sodium chloride transporters that are going to take sodium and reabsorb it actively with the help of ATP. So sodium moves out of the ascending limb, the thick portion toward the top, moves out by active transport. So it moves out of the limb, out of the ascending limb. So if I dump sodium out into this interstitial fluid around the ascending limb, what is that going to do to the water out here then? It's going to follow it, right? So if we look at, let's see, the next one here. So if we look at the osmolality across the loop, so out here, it's 300, because that's just homeostasis, interstitial fluid, 300 milliosmoles. And as it comes down here then, now water, it becomes leaky to water. But let's start over here. This is where the active creation of the gradient is occurring. If I have active transport of sodium chloride out of here, that makes it salty out in this environment. Wouldn't you agree? So if it's salty, that's going to pull water, right? So water flows out because of the salt gradient that was created in the ascending limb. So the more we lose water remember, water is flowing, right? There's a pressure here, and water, this filtrate, is flowing through the nephron. So as it flows and it continually loses water into this salty space right here, wouldn't you agree that it would get more and more concentrated because water can only leave and nothing else can enter? Because it's constantly being sucked out by the solute present in this salty interstitial fluid. So it gets more and more concentrated, then it turns, we call this the hairpin loop, then it turns and comes up, and we start to see a little bit of passive movement of sodium chloride. There's some leaking between that paracellular movement. But for the most part, it's active, and that's the key thing. So now if I start pulling salt out of here, would you agree that it would become more and more dilute? Because only salt can leave on the ascending limb, so the water has to stay. So it becomes more and more dilute as we move upward. And if we keep pulling keep pulling salt, as we get up here to the distal convoluted tubule, it's less concentrated than when we started because we pulled so much salt out of it in this thick ascending limb. So does that make sense if you look at these numbers, what's causing that? So what's the key player? What creates the gradient? Which part? The ascending limb of the loop of Henle creates the gradient. So when you think about this whole process that's going on here, you want to put like a little number 1 and say start here. This is where the action begins, is here. So we actively transport all the sodium, dump it out into the interstitial fluid. That pulls water into the interstitial fluid and creates this gradient. So then now we're up here at 100. So now we're in the distal convoluted tubule. So there's another player in this game to make sure that everybody is cooperating and we get this gradient we're looking for, and that's the Vasa Recta. So we said that the loop of Henle, specifically the ascending limb, working then indirectly with the descending limb, creates the osmotic gradient, correct? Would you agree that creates the gradient? So the Vasa Recta maintains the gradient. So what it does is if you're building up salt and fluid out here, the excess enters the Vasa Recta, so it maintains the gradient. So we're continuing to reabsorb back into the blood, because we don't want to just build up salt in the interstitial fluid indefinitely, right? It has to go somewhere. So it enters the Vasa Recta, which is right next to the loop of Henle, same shape as the loop of Henle, and it just maintains that gradient. So it just receives that reabsorbed stuff and takes it back to the blood, because that's where we want it to go eventually anyway, that salt and fluid. But here's the Vasa Recta. So don't confuse this with the loop of Henle. This is a blood vessel now. It's right next to the loop of Henle. So here we can see we've got this fluid out here, right? So we've got salt being pulled out, so that's going to cause water to come out of the Vasa Recta, but the excess salt is going to come into the Vasa Recta. So these are passive. This is passive movement through this Vasa Recta. So it's permeable to water and salt, the Vasa Recta is. So it's just basically picking up the excesses, but again, the ascending loop of Henle keeps wrecking the plan, right? So the Vasa Recta is trying to clean up, but because of the sodium pumps in the ascending limb of the loop of Henle, it keeps messing up the work of the Vasa Recta. The Vasa Recta is there to receive those excesses, but the ascending limb, with the help of ATP, keeps actively pumping more out, right? Salt. So that's the key thing. It's the active pumping of salt by the ascending limb that keeps this gradient maintained. So what happens in kidney disease? I was talking to Dr. Bonner right before class. We were chatting about this, life in the world of science people. And she said that's what end-stage renal disease is when people's nephrons die, they're no longer actively pumping salt and creating a gradient for these hormones to act on, and then people essentially can't make dilute urine, they can't make concentrated urine, they can't control their fluid volumes at all, and they need dialysis. So that's what's happening, is over time these nephrons are destroyed. So let's go to the next step now. So we're slowly building this concept. We're not there yet, so if it still feels muddy to you, that's okay, because we're not finished. So the ascending limb creates the gradient. The Vasa Recta is right there to maintain the gradient. Now we've set the stage for the key player, the boss, to come in and say, okay, I'm going to use this gradient now to maintain blood volume. So the collecting duct uses the gradient. So these are all potential questions, test questions. Creates the gradient, ascending limb of loop of Henle, maintains it, Vasa Recta, uses it to actually do what the kidneys are supposed to do, is the collecting duct. So remember, hormones act on the collecting duct. So let's just keep it easy and talk about ADH. What did we say ADH does to the collecting duct? Anti-diuretic hormone. Anti-P hormone. What does it do? Reabsorbs water. And what does it put in? What does it build into the collecting duct to make it leaky? Yeah, so it inserts aquaporins into that collecting duct to make it leaky, and water flows out of the collecting duct. And does water want to flow out of the collecting duct? Let's look at the interstitial fluid. Remember, the ascending limb created this concentrated interstitial fluid out here, right? So as this comes in at a very dilute level here at the distal convoluted tubule, if I throw some aquaporins in here, wouldn't we see water flowing out of the collecting duct because it's more concentrated out here? And as it continues to flow, isn't that going to pull more and more water out as we get down to here, 1200? That's definitely going to push a lot of water out. So if I have a high amount of ADH secretion and a lot of aquaporins, what's the most concentrated urine I'm going to form? What's the osmolality going to be? It comes in really dilute here, which means there's a lot of water here, not a lot of salt, a lot of volume here. But if I throw a lot of aquaporins with the help of ADH, how concentrated can my urine be? 1200. Yeah, 1200. Now let's say I've got a lot of fluid. Someone left the IV fluids running too long, and I didn't go to the chart. You know, I had a busy shift. This happens. You have a busy shift. You didn't get to the chart. You got a patient in a pain crisis. You got another one who's coding. So now your little patient that came in just for your little heart failure patient that came in just for some Lasix and or some pneumonia, a little dehydration. Let's say they're on 150 mils an hour. You didn't get to the chart, and you saw 4 hours, 5 hours ago the doctor discontinued those fluids. Now let's say your patient's a little fluid overloaded. Is ADH secretion going to be increased or higher than normal values? Do we want to have anti-P in a patient that's fluid overloaded? No. So ADH secretion goes down. Are we going to insert any holes in this collecting duct? No. We're going to keep it solid because we want that fluid to come out as a solid pipe, right? Get that urine out of the body. We don't want to have any holes to reabsorb it back to the blood. We want it out of the body. So this is going to be a sealed pipe. I'm trying to talk in layman's terms, but you know, it's a nephron, it's a tubule. Okay, so if we seal it, then it comes in at 100. Is any water going to come out? No. So what is the volume of my, or what's the osmolality of my urine? What's the most dilute it can be? 100 is where it comes in. It comes in at 100. Now let's say I have a little bit of fluid coming in and a little bit of salt for lunch. I'm going to be somewhere in the middle here, right? Which is typical. We're not going to be very concentrated or very dilute when we're producing urine. We're going to be somewhere in the middle, okay? But what the key thing is to understand here is when ADH inserts those aquaporins, if we don't have an increase in the interstitial fluid concentration, we don't have an ability to pull a lot of water out, right? And put it back to the blood. There's nothing driving osmosis if there's no concentration gradient out here. So the key thing is that ascending limb creates that concentration gradient. So when the hormones act on the collecting duct, there's a concentration gradient for that collecting duct to use and pull water out to help us vary our volume of fluid, okay, in the blood versus the nephron. Okay, so again, absence of ADH. So this is if we had a lot of ADH production. We're going to insert a lot of aquaporins. We're going to see a net movement of water. We don't talk about urea. That's a graduate school concept. So save that for if you want to go on. But right now we're just going to stick with water. But let's say we don't have any ADH secretion, like I said. We have a lot of fluid on board. No need to pull it back and reabsorb more than normal back to the blood. So it comes in at 100 and it stays at 100. So it's a large volume of dilute urine. So large volume of dilute urine if there's no ADH secretion or much reduced, right? Because ADH, again, puts aquaporins in there to make the collecting duct leaky and pull it back to the blood. So diuretics are medicines that act on the collecting duct and keep those substances in the nephron. Because a diuretic, to diurese, means to increase urination, okay? So dia, actually, I looked that up, and it means, the term diabetes means to stand with the legs apart, as in urinating. That's what it means. Isn't that odd? So a diuretic is to diurese, is to increase urination. And then mellitus means honey, so it's sweet tasting urine, essentially, like I talked about in lab. That's how they used to test for diabetes mellitus versus diabetes insipidus, because both cause extreme urination. Diabetes mellitus, the urine is sugary, where diabetes insipidus, it's watery. And that's another one too, is cystic fibrosis. How did they test if a child had cystic fibrosis? The practitioner would lick the skin because it's very salty in people with cystic fibrosis because they have impaired chloride transporters. So old-fashioned methods that, you know, without those fancy diagnostic tools that we have today, they had to rely on that. So anyway, osmotic diuretics then are when we have a lot of solute in the nephron, water follows solute, right? So if there's a lot of solute in the nephron, that's going to cause an increase in the osmotic pressure. Would you agree? It's going to suck fluid into the space. So if a person has diabetes because of insufficient insulin secretion, say from the pancreas, say type 1 diabetes, they're going to have high glucose in the blood. And that high glucose is going to be filtered into the Bowman's capsule from the glomerulus. It's going to be in the nephron, and that's going to pull water into that nephron. And as a result of that, they're going to have a lot of urination because of the excess sugar pulling fluid into the nephron and creating a large volume of urination. So we call that polyuria when someone is urinating a lot. And that's the first symptom of diabetes, is that polyuria because that high blood sugar. Well, the first symptom would be the high blood sugar, and then the second would be the polyuria, right? So then if you're urinating a lot, what happens to thirst? If you're losing all that fluid, you get really thirsty, and that's called polydipsia. So the polyuria comes first, then the polydipsia comes second, because you're urinating all that fluid away, you're going to be extra thirsty. So something that inhibits ADH is alcohol in higher amounts. So if you have one beer, one glass of wine, not a big deal. But if you're out for a night with friends and you're having beer after beer or wine after wine or whatever your drink of choice is, well, eventually you're going to get high enough levels of that alcohol in your blood that it impacts ADH secretion and it inhibits ADH. So if you inhibit ADH, you're not going to have a leaky collecting duct. You're not going to reabsorb water back to the blood. It's all going to stay in the nephron. And remember, we're constantly, every 22 minutes, doing our entire plasma volume. So people go back and forth to the bathroom quite a bit, right? When they say you break the seal, right? That is not a seal. It's actually blocking ADH. So now you can talk intelligently next time that happens, right? It's not going to happen to anybody in here, though, of course. We're too busy, right? Too busy taking care of people. Yeah. Or sometimes we need it more after a semester, right? But anyway, so that's what ADH does, is it blocks that, alcohol blocks ADH secretion. So the best thing a person can do is to drink water in between drinks, right? Or before you go to bed, have a nice big glass of water, because some of the symptoms of hangover are dehydration related to a loss of plasma volume. You've got a headache, right? Dry, sticky mouth, maybe your stomach's a little off. So a lot of times having just, a nice glass of juice when you wake up in the morning can help, because that can throw off your sugar level a little bit too. So then there's other substances that inhibit sodium reabsorption and water reabsorption. So we know caffeine does that, right? Caffeine is a good diuretic. People find that when they drink a lot of coffee, they're urinating more. So that's another example of a diuretic. So to diurese is a verb, and you'll hear that in the clinical settings. He's in to be diuresed. And diuresed just means we're giving them a medicine or her to make them urinate because they have too much fluid. And the most common reason is heart failure. When the heart can't pump with enough pressure to squeeze that fluid out of the capillaries, it builds up and causes the heart to fail, and then you have too much blood volume, which backs up and it leaks into the tissues, and you have edema, and it's a big mess. So people come in fluid overloaded, all swollen up. Maybe you have relatives like this, their ankles are really big, and you come in, put them on that medicine, they feel a ton better. Especially when it leaks around the lungs, they really suffer, and they feel a lot better when we get that fluid off. So a term renal clearance means that we've cleared the plasma of a particular substance. So renal clearance just means the volume of plasma cleared of a certain substance over a given time. So we look at this to see how well our glomerulus is working, is if we can look at a clearance test for a particular medicine. We can also figure out when we should redose another medicine, because when we look at Tylenol versus ibuprofen versus Aleve, they all have different dosings, right? Some are every 4 hours, every 6 hours, every 12 hours. How do we know that? Well, some of that comes from information on the kidneys. It's all filtered by the kidneys. Some are metabolized more in the liver, but for those that are in the kidneys, we know when it's not in the blood anymore, we know it's been effectively cleared up of the kidneys and we can redose. So what does this mean in the clinical environment? What happens if you have a patient with kidney failure, or you have an elderly patient with fewer functional nephrons, as happens to all people as they age? What do we know about dosing medicines to them? Yeah. So if we say, for example, we're going to dose a hydrocodone, a lower dose every 4 hours, at 4 hours, are they completely clear of that hydrocodone? Probably not. So if I give them another low dose, I could be putting them on top of one another, right? And then pretty soon by the end of the day, they're snowed in the bed, and everybody wonders why, because we've, have to give a little more time. So with elderly patients, the rule is with a sleep medicine or a pain medicine is you start slow and go low, which means use the lowest minimum dosage to get relief. So if it says, because you look in the chart and it'll say give 5 to 10 milligrams. Well, you don't say, oh yeah, she looks like she's in a lot of pain, I'm going to give her 10. Well, what you do is you look and see, what did she have last time? If she had 10 last time and you're talking to her and she's been there a couple days and she looks good, well then yeah, give her the 10 if she's rating it at a high pain. But if she hasn't had any, then you start at the 5. You never throw 10 at people until you know how they tolerate it. And some people can be young and just have low tolerance to some of these medicines, right? So you always, start low. Okay, and also we look at, how well their kidney disease, because kidney disease is staged. It's 1 through 4, I believe. That's what I've seen anyway, but 4 is the worst. So we can look at renal clearance again of certain substances and determine, how to stage kidney disease. So there's a formula for it. I'm not expect you to memorize the formula, but you should understand the concept, right? So the faster the flow going through, would you agree that it would be cleared faster? Renal clearance would be higher than if it's flowing slowly through the system? And the concentration, obviously, the more substance in the plasma, the longer it's going to take for it to be cleared, right? So those are pretty basic. So again, just understand the concept that's represented by the formula. I'm not going to make you calculate anything. But typically we can say that for that substance, if the flow is 125 mils a minute, that's the glomerular filtration rate, how fast the glomerulus is moving fluid into the nephron. Then if the renal clearance is less than that, we know that that substance is reabsorbed. So if it's less than the filtration rate, if it's equal to 0, then we know the substance is totally reabsorbed, so it's not going to be in the nephron. And then if it's greater than 125 mils per minute, that the excess will be secreted. And that's like drugs that we take that are broken down. Obviously, we don't want those to remain in the plasma. So the last part that we should talk about before we switch gears a little bit into acid-base is looking, and then we'll take a break, is looking at the process of urination. If we think about how the nervous system interacts with the bladder, it's important to understand sympathetic versus parasympathetic. So which one do we say is the rest and digest? Parasympathetic. And when you think of the parasympathetic nervous system from a clinical standpoint, think of it as the wet system, which means salivation, tearing, urination, those are all parasympathetic activities. So when we're talking about binding to receptors, right, and trying to promote digestion, we know that salivation promotes digestion, right? So those neurons that either secrete norepinephrine or they secrete acetylcholine. Do you remember when we talked about that with the autonomic nervous system? So there's adrenergic neurons. Those are the ones that secrete adrenaline, which we call epinephrine. That's the sympathetic nervous system. And then the parasympathetic nervous system, we said, was cholinergic neurons, because that postganglionic neuron secretes acetylcholine. So we have to determine what in the urinary system we want to promote. If we want to promote urination, we want to promote parasympathetic neuron stimulation, right? So if we look at the bladder wall, if we want to, increase urination, I'm trying to get on the right path here. So to increase parasympathetic activity causes the muscle that controls the sphincter, the muscles of the bladder wall, first of all, contract, and then the internal urinary sphincter opens with parasympathetic stimulation. When we send an action potential down cholinergic neurons and they bind to what type of receptors? Here. Putting it all together now, end of the semester. What? Muscarinic receptors, yes, very good. So all parasympathetic effector organs have muscarinic receptors for acetylcholine. So when they're bound, it causes, in this case, because it's urination, wet, 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 it's going to cause the external urinary sphincter to open and water's going to, or fluid, urine is going to flow, but we can control the external urinary sphincter. So that's when you feel that little urge and you consciously contract and say, no, not right now. And then you inhibit that reflex, right? And we can shut that down for a while. So we can stimulate the somatic motor neuron going to the external urinary sphincter, again, causing it to constrict and say, not right now. And that process inhibits parasympathetic activity, increases sympathetic activity, and basically then our brain is just saying, not right now. So we have the ability to suppress this reflex. This is definitely a reflex because as the urinary wall stretches, that causes action potentials to flow into the spinal cord, which travels through parasympathetic neurons and again acts on that internal urinary sphincter. But we can override that. So we don't have what we call micturition. Micturition is the fancy name for urination. So when it comes time to actually urinate then, and I'm sure all of us have experienced this, you have to urinate bad. So you're sitting in class, you had a bunch of coffee before you came here, or maybe a large soda, and you're like, come on, when is she going to be done? And then you get to the bathroom, and as you get in the bathroom, maybe you have, and for the girls, I'll just use that as maybe you have a difficult button or belt, and you're like, oh my gosh, I really got to go now, right? That is the micturition reflex. You're thinking about urinating, and that reflex is sending action potentials very quickly, and that's why we have to be careful with our kids when they're potty training to say, you made it to the potty, you just have to sit on the potty instead of peeing next to the potty, right? But that's the reflex that happens, so it's not their fault. And think about that in terms of your patients too, how humiliating and upsetting it is for an elderly patient that has problems with frequency or control, and you're like, okay, in a minute, yeah, I have to go to the bathroom. You say, in a minute, when it works for me, right? That's not how we should be as healthcare workers. If they say they have to go, even if we have these other tasks we have to do, if they're not life-threatening, obviously, make that a priority, because once that reflex kicks in and they're thinking about urinating, it's going to happen. So that's the sympathetic, or the parasympathetic reflex causing stretch of the bladder wall to reflexively contract the bladder wall to encourage urination. So what's the only thing we have control over in this? Which square do we have control over, conscious control? Yeah, the external urinary, or external urethral sphincter. Because what controls it? A somatic motor neuron, and that's what we have voluntary. So that's skeletal muscle, right? So what is the internal urinary sphincter made of, do you think, if it's controlled by the autonomic nervous system? Smooth muscle. Yeah, so another test question potentially, right? Okay. Some people have an inability to respond to that reflex, and we call that a neurogenic bladder, and that's the #1 reason why you'll see people in the nursing home with long-term urinary catheters, because they they have no control over that reflex. And so there's no point in trying to, get control, because it's not possible. And those people have chronic underlying UTIs, and don't expect that they're not going to have a UTI. If we give them really good care, do really good peri-care, impossible. The chance of a urinary tract infection after day 3 or 4 of having a catheter is greater than 70%. So what happens is bacteria outside the catheter, I mean literally outside the catheter, they create like a film. It's called a biofilm, and it comes right up the outside of that catheter and crawls right up into that sterile urinary tract, and they're bound for infection. So the best we can do is try to keep the infection at low levels, and hope that it just maintains inside the urinary tract and doesn't spread and make them become septic. But it's a constant problem. And some of you who worked in the nursing home or do work in the nursing home may know people that have chronic urinary tract infections. But the best thing we can do in the hospital situation when they've got a temporary catheter is make sure we're giving them good peri-care and keeping that catheter clean at all times. Make sure when it comes time, if you're going into nursing and you have to insert a catheter, make sure you're taking total respect for the sterile procedure that it is, and that you get someone to help you, because CNAs are great for helping you hold things and hand you things, because you have to keep a completely sterile hand when you're inserting that catheter. And also, it's frustrating sometimes for nurses when they have a confused elderly patient that has a urinary frequency when the doctor pulls the catheter. And now we need 2 people to help her to the bathroom. She's on the light all the time. She's diuresing. Why did he do that to me? I'm a busy nurse, right? Well, it's better that than having a urinary tract infection and complicating things more. So they do have to pull those catheters by day 2 or 3 if they can. Yes? Mm-hmm. That's true. Yeah. As long as they're using sterile as long as they're using sterile equipment, you know, straight cathing is preferred because as long as, like we had a patient that came in, he was reusing catheters and he had UTIs constantly. He said he just couldn't get them clean enough. And he was, you know, using what they recommended to clean it, but it just wasn't good enough. But when he used a brand new sterile catheter every time, no problem. And that's why it is preferred, actually, to straight cath repeatedly than to have, again, it creates that film and they can just crawl right up there and it's, you know, and the peri area in males and females is a dirty area. There's bacterial and fungal organisms that live down there and you've got that tube right there going into a sterile environment that's warm and moist. It's just a perfect breeding ground for a urinary tract infection.